Welcome back, everyone, to Pulm Peeps. We have been doing some amazing case files with fellows across the country, and so excited to visit a new pulmonary critical care fellowship today. And Furf, how are you feeling about it?
Oh, the best. This is my favorite part of the week. I do want to stop and to congratulate you, Christina. This may, by the time this episode comes out, it'll be fully public information, but you're taking over as the fellowship program director down at Hopkins. So congratulations. It's awesome. Your fellows are going to be very, very lucky.
Thank you so much, and very much looking forward to it. And as you said, hopefully by the time this airs, it'll be public knowledge.
So today we're visiting the University of Rochester. We're really excited to add this to our list, and this will definitely be a stop in our in-person tour. I'm a huge Buffalo Bills fan, so any excuse to go up to Bills country.
Yeah, I love it. I feel like for even one time, I feel like we rescheduled because it was the Bills were in the playoff game. So you do take that very seriously, and I respect that.
You have to have your priorities. Right?
For sure. We're so excited to introduce our first guest today. We have Dr. Shiv Patel. Shiv completed his IM residency and a chief year at the California Pacific Medical Center Van Ness campus and is currently a first-year pulmonary critical care fellow at the University of Rochester. We could say at the time of this, at least 9 months done of your first year, which is amazing. So a few more months to go. But we're really excited to be highlighting the University of Rochester Pulmonary Critical Care Fellowship and really have you lead us through a fantastic case today, Shiv. Honored to have you on and welcome to Pulm Peeps.
Thanks so much. Really looking forward to getting into this case today. Appreciate it.
Yeah, absolutely. And next we have Dr. Marianne Morgan. Marianne is an associate professor of medicine and the fellowship program director for the Pulmonary and Critical Care Medicine Fellowship at the University of Rochester. Her clinical interests range from the care of critically ill patients in the ICU to the diagnosis and management of rare lung disease in her role as the director of the University of Rochester Lamb Clinic. Ooh, a topic that we still have yet to cover that is on our list. So we may be reaching back out to you. She loves unwrapping clinical reasoning with trainees, exploring issues around communication and teamwork in the ICU, and is excited about curriculum revitalization in the growing University of Rochester Medical Center Pulmonary and Critical Care Medicine Fellowship Program. Thanks so much for coming on today, and welcome to Pulm Peeps.
I'm thrilled to be here and just want to thank the two of you for doing such a great job with the clinical reasoning piece for all of our trainees.
Absolutely. It's our pleasure. So before we dive into our case, just a standard disclaimer. As a reminder, this podcast is not meant for specific medical advice. The views we express today may not reflect those of our respective employers, and the case we present today will be HIPAA compliant. Some details may have been changed to protect the privacy of our patient.
Great, and excited to go ahead and get started. And Shiv, sounds like you have a really great case that you encountered while you were on one of your recent inpatient ICU rotations. So why don't you tell us a little bit about things, how your patient initially presented, and we'll go from there.
Sure, sounds great. So this patient is a 75-year-old female with a history of hypertension, hyperlipidemia, and type 2 diabetes who had presented chiefly for evaluation of hypoglycemia and generalized fatigue. She had felt poorly for about a week with symptoms of back pain, generalized weakness, and dyspnea, all of which acutely worsened on the day of presentation. It was actually a home visit by the patient's daughter that actually prompted the hospital visit. The daughter noticed that the patient had slurred speech at home and called EMS. When EMS arrived, she was found to be hypoglycemic with a blood glucose level in the 40s, which was treated with an AMPA-D10. And her vitals included a heart rate of 56, blood pressure of 70/40, a respiratory rate of 30, and a temperature of 28.5 degrees Celsius, or around 83 degrees Fahrenheit. Given the bradycardia and hypotension, she was given atropine by EMS with a mild improvement. And upon further questioning, she admitted to recently having decreased urine output, and despite feeling poorly, she'd been taking all of her home prescribed medications. I know this is a brief history so far, but Dave, what is your problem representation, and what are your initial thoughts about our presentation?
Yeah, this is really interesting. A pretty standard way that some very sick patients come to us, very undifferentiated. A 75-year-old woman with a history of really metabolic syndrome and everything that goes along with it, who's coming in with a variety of abnormal vital signs and hypoglycemia. You know, the tough things about these cases is figuring out and unraveling what's chicken or egg, right? So a lot of these things can cause each other, right? If you're hypotensive, you can become hypoglycemic and then bradycardic, and vice versa. You could be hypoglycemic to start, and that can trigger a lot of these things. So, we're going to take a broad approach. We think common things being common about septic shock and someone having an infection, which can cause all of these types of things. And we're going to, I'm sure, treat aggressively for that. I like to kind of focus on the hypothermia here with the hypoglycemia. 83 degrees Fahrenheit, pretty cold for a person going in. Usually the type of temperature you see in someone who has exposure, and this history is really not that consistent with exposure. So you always want to think about that. But being hypothermic itself can cause all of these other abnormalities. So things that I think about in that hypoglycemia, hypothermia bucket, I think about certainly endocrinopathies. You could be in adrenal crisis, you could be in hypothyroidism or myxedema coma. I think about patients having neurologic disorders or things that are preventing them from regulating their temperature appropriately. This can happen actually just with like very old people who are unable to shiver, but certainly people who have Parkinson's or hypothalamic dysfunction, sort of CNS dysfunction, who have issues regulating their temperature can present like this as well. I definitely think about medications in a patient like this. She has metabolic syndrome, hypertension, hyperlipidemia, type 2 diabetes. She's presumably on a number of medicines. So things like antihyperglycemics, beta blockers, we don't use them as much, but alpha agonists like clonidine can do things like this. And then certainly anything that just stops someone from thermoregulating. So we see this with opioids, antipsychotics, antidepressants. When people overdose, they just don't regulate their temperature very well. And so they can present like this. So I'd be curious about all of that. And then in terms of ingestions as well, anything that causes liver failure can cause something like this. So, certainly I'm going to be sending labs to see what her hepatic function is going on as we get some more information. And then finally, I said with sepsis, but we should remember that sepsis is not always just infection. We should think about like broad inflammatory disorders. So somebody who has pancreatitis, somebody who has a widespread malignancy that's really gotten to an inflammatory standpoint could present like this if things have gone unregulated or undetected. So similar to some of our other case files, in this, we're definitely going to be gaining more information, but that's going to be collateral information because probably this patient's not going to be able to tell us all that much in her current condition. But hopefully you can tell us a little bit more about her history and past medical history that you found out.
Absolutely. So fortunately, we were able to get some additional history. This included a history of stage 2 CKD and bilateral total knee replacements in 2012. This is in addition to her hypertension, hyperlipidemia, and type 2 diabetes that we mentioned. She had no alcohol, tobacco, or illicit drug use. And we got a home list. Her home medications included lisinopril, hydrochlorothiazide, triamterene, atorvastatin, metoprolol, glimepiride, and metformin.
I appreciate you sharing that, Shiv, and I think definitely from some nice collateral information, particularly having an updated medication list, and as you mentioned, getting some information from the patient directly, but then also having some additional collateral from her daughter. Furf appropriately brought up that we should be thinking about toxicology etiologies for her presentation, and Shiv, you mentioned so many offending agents on her home medication list. Right. And this is someone in their mid 70s on multiple medications with known CKD. Anything could have just tipped her over, predisposed her to AKI on CKD, leading to, severe electrolyte derangements, particularly with the lisinopril, her hydrochlorothiazide, as well as a triamterene. With atorvastatin, thinking about statin toxicity or intolerances should be considered, fatigue, myopathies. But I don't typically associate that with, the shock or hypothermia or the hypoglycemia, but something that may be contributing as well. Firth mentioned the liver failure. Could this be coming into play? Definitely beta blocker toxicity could be certainly explain the bradycardia and hypotension. The classic teaching with this is it can also result in impaired glucose metabolism, leading to hypoglycemia, which she mentioned as one of her presentations. We had a great case on calcium channel toxicity. We haven't done beta blocker yet, but something for us to keep in the back of our minds. And then lastly, mentioning the glimepiride as well as the metformin, both have associated toxicities, can lead to hypoglycemia and some of the other things that we've seen. So still with this extremely broad differential, but I think we need some additional information, Shiv, including, repeat vital signs. What was her initial physical exam like, which may change our hypothesis. So I'd love if you could share, her initial evaluation when she presented to the ED.
Sure. When the IC was consulted, this is down in the emergency department, her vitals included a temperature of 34.7 degrees Celsius. Her blood pressure was 82/42 on norepinephrine with the recent addition of vasopressin. Her heart rate came up to 91, and her O2 sat was 100% on BiPAP settings of 10/4 with an FiO2 of 40%. On physical exam, we were able to see that she was alert, able to nod to questions, but was pretty lethargic on BiPAP. Her cardiac exam was notable for a sinus rhythm without obvious abnormalities. Her lungs were clear to auscultation bilaterally, but she was tachypnic and taking deep respirations. Her abdomen was soft, non-distended, and non-tender, and the lower extremities had 1 to 2 plus edema. The exam was non-focal otherwise, all things considered. An X-ray that was obtained in the ED showed low lung volumes with bivascular patchy airspace opacities and a possible small left pleural effusion. And a POCUS was performed by the overnight fellow who found that the patient had a hyperdynamic LV, a collapsing IVC, and a grossly normal ejection fraction with no focal wall motion abnormalities.
Great. And I know people are like, what are the labs showing? We'll get to that in a minute, but so important to, use physical exam and other, supplemental information that we can get from diagnostics, including the x-ray as well as POCUS. And kind of putting this patient together a little bit more, Shiv, you're based on the exam and the data you provided, right? She seems to be in acute respiratory distress. She's in dual vasopressor shock. And I think just worth mentioning the POCUS a bit more, right? An adjunct that we can use to our physical exam, and particularly the finding of the hyperdynamic LV, as I think this is a common finding seen in the ICUs. And I know, when I'm in our MICUs, our fellows will like pull up their POCUS images and be like, this is normal or this is hyperdynamic. And, it's always a good kind of teaching for the house staff as well, right? Because when we think of a hyperdynamic LV, this is going to suggest hypovolemia as well as peripheral vasodilation. Severe cases, I'm sure we've seen, end systolic obliteration actually of the left ventricular cavity. So I think important to point out and important to work with trainees to make sure that we're understanding this when we're actually seeing the image. So, based on this, Verf had mentioned, thinking of shock very broadly, but based on this POCUS, we may be able to say, cardiogenic shock may move down. We're still somewhat in undifferentiated territory. And Marianne, I know that you work closely with trainees in your ICU, and I'm wondering if you could just share with us a few highlights of how you teach trainees to think about shock in an ICU setting.
I would love to. This is one of my favorite topics to teach on, and often I will go on for an hour, so I promise not to do that here. But I want to make a couple of main points, just as you asked for. So the first point, really, when you're considering how to approach shock is the importance of recognizing it early. So in what they almost call that pre-shock state, which I think of as sort of, as you're going up the hill on the roller coaster and things are going slowly, that moment sort of right before the free fall. And this is incredibly important and often overlooked. So if we have the opportunity to intervene early, we know that it makes a big difference. And especially in patients who are young and have a lot of reserve, if we wait until the numbers look bad, then we're missing an opportunity. So how do you recognize it early? Well, we have become really reliant on the electronic medical record, which is amazing. And there's a lot of tools there, including lots of sepsis alerts and things that pop up. But really, for me, I like to go back to the old-fashioned get to the bedside, because I think just looking at a patient and doing a very quick, focused exam tells you so much that you can't get just from looking at numbers. So for me, my focused exam really consists of how are they breathing? Are they looking like they're putting a lot of work into it? I know they may be oxygenating fine, and that's great, but we also know there's a lot of opportunity between the normoxia and the elevated work of breathing before the oxygen drops that we can intervene on. And if they are breathing hard, is it short and shallow and quick, or is it deep like this patient was doing with the large tidal volumes? I'm also looking for signs of hypoperfusion before they become hypotensive. So I remember as an intern, a senior nurse saying to me, always pull down the blanket and look at the kneecaps. And I thought she was a little bit nuts, I have to admit. But I do this all the time now, because if you do see modeling, it's not super sensitive, but it's a very worrisome sign to me when I see that. Of course, capillary refill is helpful too, but doing that appropriately requires some patience. And then, skin turgor and things like that. Of course, we're also in this very brief focused exam looking for those things that you can't miss. So even before we bring out our ultrasound, is there tracheal deviation? Do they have peritonitis? Is there areas of necrosis in the skin? We've seen so much neck fash this year that, making sure we're really looking at their skin and their extremities is so important. And then with the POCUS, so those are sort of our natural senses that we come born with, a lot of us, hopefully. The POCUS we're not born with, but it is also an incredibly important part of the physical exam. And for me, again, in this circumstance, is about almost ruling out things that are less typical. So, do they have huge pericardial effusion? Is there lung sliding? Is their RV like a floppy balloon? Is their LV like barely quivering? Like those are the really important assessments initially. And I really kind of focus on initial because my second teaching point, I think, is that sometimes as internists, we're very obsessed with getting all the information before we actually start solving and acting upon the puzzle that's in front of us. So I think of my approach to shock in two phases: this initial approach, where I'm really just trying to get as much information as I can and getting things started in terms of support. So norepi is almost always the right choice for a pressor. It's almost always okay to give some fluid, though you have to be cautious, of course. It's almost always right to do cultures and broad antibiotics while you're still in this undifferentiated state. And those are the things that you want to make sure are happening quickly. That second phase, then, the second teaching point is sort of not letting perfect be the enemy of the good, as they say. So, instead of like trying to get the best images with your POCUS or perseverating on getting the art line in, this is the phase where you need to just start using your brain as well as doing the things again to support the patient. So really focusing on kind of the non-fancy stuff initially, so the ABCs part of it. I wish that all patients fit nicely into those little categories of sepsis. And you had mentioned this earlier. We all memorized and learned distributive versus cardiogenic. What are the classic findings in each? And I think if we anchor too much on that, we miss the opportunity to see that oftentimes, for example, in sepsis, the heart isn't working so good initially, right? Oftentimes in cardiogenic shock, the patient may have bacterial translocation that's contributing to some more of a distributive type picture. So it's important to think about those categories, but trying to define it early on is often more trouble than it's worth, frankly.
Yeah, it's great points about having to act quickly and with the information you have. And I love the way you presented the case, Shiv, because this is actually how it really kind of should happen. Like, yeah, you want to get labs, as Monty said, but you should be at bedside. You should have probably a POCUS before that first round of labs comes back for someone who's super sick like this, so that you can start acting on those things right away. And Monty, I love your point about the LV cavity obliteration. We just had a case like this where they look like cardiogenic. Everyone's like, they're cold, they're hypoperfused, but they're just slamming LV and they have this dynamic outflow tract obstruction and they haven't been resuscitated. So, really important point for everybody. Well, I'm excited to learn some more, and we got some good info right now. Shiv, could you just tell us a little bit about the rest of the diagnostic evaluation?
Yeah, absolutely. So, initial lab work had several notable abnormalities, as everyone is probably assuming. The sodium was 130, potassium was 6.4, chloride was 86, and the bicarb was undetectably low below 7. And so the anion gap was at least 39 in this patient. The FOS came back at 15.2. The BUN was 93 with the creatinine of 8.58. The CBC came back with a white blood cell count of 14.1, but had a normal differential and was otherwise normal for hemoglobin platelets, etc. Our LFT was only mildly elevated, and the PTINR was normal. The lactate resulted at 15.3, and our ABG was done. The pH was undetectably low, less than 6.8. The CO2 was undetectably low at less than 15, and her PaO2 was 81. As everyone comes through the ED, they get tested for COVID, and her test actually came back positive. And an A1C that was sent out came back at 10.4. A repeat x-ray was done after a central line was placed on the right neck that looked about the same as previous, maybe with a little more mild pulmonary edema. And a formal echo was obtained that confirmed many of the findings from previous. Her ejection fraction was around 70% without any significant regional wall motion abnormalities.
That's great. Thanks, Shiv. A lot of information to work with to sort of update our problem representation. So we have a 75-year-old woman we can pretty confidently now say is in shock given her hypotension and evidence of end organ malperfusion, who has a severe lactic acidosis, a severe acute kidney injury on chronic kidney disease. Really looks like she's progressing to renal failure based on her electrolyte abnormalities, and a severely depressed pH, who's actually maintaining her respiratory status pretty well, given the amount that she's been able to ventilate and oxygenate currently. So interesting how a couple of years will make a difference. 2 years ago, this would have been COVID rip roaring and the primary. And now we often have these in their incidental findings, but it could be for her that this is the primary. I think that one thing that's helpful for these cases is the time course of like, who was this patient beforehand? So the patient like this could have been at home 3 weeks, they're not doing well, and they have this kidney failure and it's progressing and they get here. Or it could be someone that you saw 3 days ago and then now, or 2 days ago, and then now they're in severe shock with severe acute kidney injury. So that can really help you think about your differential. That being said, in this patient, we are clearly going to be aggressively managing shock, right? And trying to restore end organ perfusion, make sure that we're adequately volume resuscitated, as Marianne said, using broad spectrum antibiotics, sending cultures till we know more about what's going on, and probably getting some more imaging. But one thing I want to focus on here is her profound lactic acidosis. This is impressive lactate and impressive acidosis. And the reason we talk about this so much is just like how important it is in the data for patients. So there's this one great study that shows that if you don't half the lactate or get the lactate to less than 4, whichever is the lower number, within the first 4 hours of the patient's hospitalization, their mortality is up by about 50%, right? So like this is something we want to correct really quickly. And so I'd love to just sort of review the different types of lactic acidosis and what this has us thinking about. Shiv, I know that you were thinking about this, and if you could tell us about your approach to lactic acid, type A's, type B's, and then sort of what you're thinking.
Yeah, sure. So, when I think of lactic acidosis, I do break it up into 2 buckets that we traditionally are taught, the type A versus type B lactic acidosis. The type A typically being secondary to conditions that impair oxygen delivery to tissues or decrease tissue perfusion. And the delivery component can be something like respiratory failure or PE, whereas perfusion can come from severe anemia or shock, such as possible in this case. And the thought is that this leads to anaerobic metabolism and subsequent lactate production, which we're finding on our labs. Patients typically present with hypotension, tachycardia, tachypnea, altered mental status, and signs of organ dysfunction. The type B lactic acidosis is actually secondary to conditions that directly affect cellular metabolism or lactate clearance. And this can be characterized by the presence of hyperlactemia without evidence of tissue hyperperfusion or hypoxia. Conditions to think about include liver dysfunction, such as liver failure or cirrhosis, malignancies, especially hematologic malignancies, and medications and toxins such as metformin or cyanide poisoning. There are the few and far between inborn errors of metabolism and mitochondrial disorders to think about, but all things considered, that's a good way to think about the type A versus type B. So for this patient, although she had significant hypotension, which could have been causing a type A lactic acidosis, there was not a rapid improvement in her lactate despite fluid resuscitation. And so her blood gas in clinical history had us concerned that there was a predominant type B acidosis at play here.
Also point out, because this always comes up by residents, is it's type D lactic acidosis, what people will talk about. And just to point out, like, unless you have short gut syndrome and you have no small intestine, this should like not be on your differential. And if you do have that, then it should be on your differential. But that's a great thing of the primary. And often we see these lactates at first and we're like, all right, well, we just got a fluid resuscitate, and then they don't go away and you're like, okay, now it's time to start thinking about what's happening here.
Yeah, I definitely love that point, Shiv. And like for me, I think, particularly I work in an oncology ICU. So a lot of our patients have known, hepatic cellular carcinoma or, metastatic disease coming in with high tumor burden. And some of our initial consults were like, oh, like this lactate is 6 that hasn't responded to fluids. And it's like, well, like, I don't think this person's in shock and they don't have signs of, end organ perfusion abnormalities, and they're alert and oriented, talking to me perfectly fine. So it's just like having that conversation though, and kind of thinking more of just about the actual lactate number. But that was such a great review, Shiv, that you did for us to remind us the difference between type A and B, and for bringing in that type D. I wanted just to point out there's a great on-the-fly teaching and ATS scholar by our prior guest, Robin Stiller, as Bashat Kaura, on all that raises lactate is not sepsis. So it's like 2 pages. It's a really great read. They have a great figure for those that may not be able to remember the metabolic pathways, such as myself, that cause hyperlactatemia, and many of which you cover, Shiv. So just wanted to point that out. So in this patient, right, she's critically ill, as we've alluded to. things are being done simultaneously, as Marianne mentioned, starting giving fluids, starting her on norepinephrine, vasopressin was added as well, likely starting empiric antibiotics. I think given the amount of her home medications and the potential toxicologic effects that could be caused by them, I think that this would be a case where it would be important to get toxicology colleagues involved early as well. And Marianne, I'm just wondering if you can comment on, when do you like to actually talk to poison control centers? If you could just share your approach and maybe what's done at your center.
Absolutely. We are so fortunate here at the University of Rochester that we have a 24/7 rounding toxicology service that's staffed by tox experts. And if I had a Rolodex, they would be in the front and center. But they're one of my favorite services to consult because, as you're pointing out, sort of recognizing early on when patients aren't responding to traditional measures to reverse shock, or if there's something atypical about the presentation, you want to be able to identify any potential culprits quickly. And so bringing them in early, anytime that you have a complex overdose or something that seems like a toxidrome, but you're not sure, or if there could be a toxin contributing to the overall picture, even if you've identified another, major etiology. I find them to be incredibly helpful in this way. I'll never forget it as a brand new attending managing a young person with a Wellbutrin overdose. And all of a sudden this person shows up at the bedside, and it happened to be my brand new toxicology colleague. And he stood there with me as I was doing all the procedures and he was doing all the thinking and just working closely side by side to try to resuscitate a really sick patient showed me the immense value of having experts in toxicology. In a way, not to say that I'm lazy, I don't think any of us are, but having someone else with this expertise allows me to, and knowing that I have confidence that they're thinking about it and managing and helping us deal, I can focus on all the other stuff, right? I can make sure that the consults have been called and I've ordered the right tests and the patient's family's been talked to and all of that. So I really am a champion of toxicology in a lot of different circumstances, even if they just sometimes say, yeah, your patient's encephalopathic, but it actually isn't a toxidrome. Like, oh, good. Thank you so much. And that's ruled it out for me. So I find that I pretty much always learn anytime tox is involved in the care of one of my patients.
Yeah, thanks so much. And for people who don't know toxicology, poison control can often fill this role somewhat. And anytime I've had someone who calls them for the first time, they're always at the same response, just like, "Oh, I'm calling them all the time." Like they're so helpful. They so follow up. They have so much insight into cases that you just may kind of overlook in your ongoing, very acute care that you're providing. So Shiv, can you tell us how we've talked about what could be going on for this patient, but how their care progressed over the next couple hours?
Absolutely. So the patient was actually kept on BiPAP at the settings I mentioned previously, 10/4 and 40%, to assist with the workup breathing that she had and their severe metabolic acidosis. Bicarb boluses and bicarbonate containing fluids were provided to try to get to a pH greater than 7. She was given broad spectrum antibiotics, vancomycin, cefepime, and flagyl empirically, and stress dose steroids were started as well. Both nephrology and toxicology was consulted, and CRRT was initiated. So, that right IJ line she has an HD line. And her blood pressure was supported with norepinephrine and vasopressin. Phenylephrine had to be added to try to keep MAPS above 65 as well.
Thanks, Shiv, for sharing the management. And still, as Farf mentioned, still surprised that the 75-year-old is able to have the reserve to overcome this severe acidosis. So, but thank you for sharing what was done for her. And as you mentioned, escalating doses of vasopressors with an addition of a third vasopressor, right? And it seems like this could all just be secondary to severe shock, but also something we should consider further is metformin-induced lactic acidosis and renal failure. And Shiv, I'm sure you had the opportunity to review this in more detail while caring for the patient, and would love for you to share some highlights that you learned from this case. Those listening today.
Oh yeah, and before you do, Jim, I wanted to mention one thing that Christina, as she was talking, I was thinking about was that it is so interesting the respiratory status, and then sometimes that makes me think a little bit less about sepsis, right? Because we often see people who are septic have leaky vessels. It's usually leaking their lungs. They often get an ARDS or respiratory stress. people who have aspirin overdoses or other toxidromes that have this bad acidosis but can keep up with their lungs. It's just unusual. It's not unheard of, but it's unusual. And, just to point out, this would be a person I'd be so scared to intubate, right? Because there's no way you're going to keep up with their hypoventilation to get their PCO2 less than 15 like she was doing on her own. So just, I would be really terrified if we got to that point and had to do it.
And I think the other factor, if I may say so, that leads us away from sort of assigning septic shock or some other distributive shock completely as the one and only cause of this and looking at tox is that having a pH less than 6.8, if this were all hypoperfusion, if she had a complete dead intestine plus other things, I don't think she would still be alive at this point, let alone able to take these 1 liter breaths and communicate and things like that. So it really kind of makes you take a second look at things.
Yeah, it's a great point. And it's great and important to consider, because if you don't take a pause and consider those things, you might miss, important diagnosis. So sorry, Shiv, I'm very excited to hear everything else going on and the highlights you want to share.
Yeah, of course. So, I want to give a quick shout out to my co-fellow Bashal, who's actually excellent decision making overnight, really laid the foundation for our ICU course to be short and sweet throughout the rest of her stay with us. I had a few teaching points. The first being that the patient's profound hypotension was managed with this tried and true combination of norepinephrine and vasopressin, 2 first-line vasopressors that data does support the use of in septic shock. And after maximum doses were met, phenylephrine was added. Her relatively normal cardiac function on POCUS reassured us that any additional afterload that she'd have from phenylephrine could be handled without issues. If she had continued to become hypotensive, adding epinephrine would have been the next step. I think having a sequence of pressors in mind, if needed, really helps decision-making run smoothly. Secondly, as you guys have mentioned, this patient had a severe metabolic acidosis that she was thankfully compensating for between her tachypnea and tidal volumes of 1.5 liters on BiPAP. If she had COPD or any other underlying lung disease, I think the story would have been very different. Since her mentation really improved after glucose administration in the field, we felt it was safe to support her breathing with minimal BiPAP settings and keep a close eye on her if she had signs of tiring out. And as you had mentioned, if intubation was needed, attempting to match her pre-intubation minute volume would have been really key to reduce the risk of adding a respiratory acidosis on top of her existing acid-based disorders. With regards to this metformin-induced lactic acidosis and renal failure, toxicology data actually supports the use of intermittent HD over CRRT to essentially rapidly eliminate metformin over a 3 to 4 hour session and really normalize things. Now, unfortunately, her blood pressure was too low to comfortably do that, so CRRT was initiated overnight and was actually continued for the following day and a half. Slowly but surely, her lactate came down from 15 to 10 to 5 to normal, and blood gases improved as well. Her vasopressors were weaned, and she was generally breathing easier over the next day and a half.
Can I just say two things I'm really grateful for in this case? One is that the COVID did not cause ARDS, because we certainly wouldn't have been able to allow her to take these enormous breaths. Thank goodness she didn't have obstructive lung disease. And then the last part of it is that I do think of these patients as being similar to my patients with severe status asthmaticus or even, severe RV failure in terms of risk of intubating. Because I think you mentioned very early on, trying to match this minute ventilation after you've sedated and paralyzed somebody is really, really difficult. So we'll usually see a drop in pH. And at this point, we could not, at least temporarily after intubation, and at least in a situation like this, for this patient, we could not afford any further a drop.
Great, Shiv. And I feel like I can imagine this kind of like on the fly teaching, like in the ICU with the team. You're kind of reviewing the toxicology data together and trying to come up with a plan. Yes, I think that's a great, learning point, as you mentioned, that the data supports intermittent IHD over CRT. But in this patient who was on multiple pressors, that wasn't quite possible for her, but still impressed with such a rapid improvement. And as I think we've all alluded to in different ways, thinking something outside just traditional shock picture and how she was able to improve based on the underlying complications from metformin. So Shiv, hopefully you could tell us, it seems like she's had some rapid improvement, but can you just kind of close out the case for us and kind of what happened next with as far as her management goes?
Yeah, sure. So she was in the ICU for a total of around 2.5 days before she was transferred to the floor. She overall had a mild course of COVID without any respiratory issues. She was found to have a Klebsiella UTI, and Perhaps this played a role in her initially feeling poorly outpatient and could have played some part in her COVID and UTI combination on top of medications that she was continuously taking with poor PO intake, which led to this inevitable hospitalization. Lisinopril and metformin were stopped, and she was started on nightly Lantus with outpatient follow-up with endocrinology. Her creatinine slowly improved at a recent visit, actually just 2 weeks ago, and reached its baseline of 1.2. So all things considered, she had a relatively short ICU course and hospitalization, and things rapidly improved.
Yeah, that's incredible, right? Someone comes in this sick looking with those abnormalities, and then just 2.5 days later, you would never sort of guess it when you're first approaching them in the ED, I'm sure. Well, this is a great case, a lot of great teaching points for everyone. We're really excited to, share these fellows' case files and to add a new hospital and a new program to our roster. We love building this network, and I'm sure we're going to be in touch about other learning opportunities and things that come up. But we just love to hear a little bit more about University of Rochester, what you guys like about practicing and learning there, what you value about the hospital and the training there. So please, we're all ears. Shiv, maybe we'll start with you.
Sure, yeah. I've really enjoyed this past year of training at the U of R. I'm really looking forward to the next two. Thinking back on it, I've really come to value the relationships I have both with my co-fellows, but also with all my attendings and just how open they are to teaching and having conversations around the management of patients' conditions. It's also been surprising to me just how large of a catchment area we serve in this Western New York area. With that comes really interesting medical cases, but also folks that are really eager to get care where they otherwise couldn't due to just geographic restrictions. So it's been a great time.
And I didn't even pay him to say that. I want to share, for me, it's all about the people. I am so lucky to have amazing colleagues that I can lean on and amazing consultants that will help in the care of patients. And then I'm just so fortunate to be able to be the program director for an amazing group of fellows. I'm really excited that we're actually expanding our program significantly this coming year. We've built our faculty. We have an amazing division head and Dr. Patricia Rivera. And it's time to make sure fellows get the opportunity to benefit from all the teaching that we have here. So really excited to shepherd a larger group of trainees into this wonderful field that we share.
This is an awesome case. Thank you both so much for joining us. We like to end the case with just a teaching point or a thing that you're going to remember from this for our listeners to sort of end their commute and their listen with. So mine is going to be one that, Marianne, that you said, I feel like a broken record when we say this about shock, but it's really about getting there by the bedside, doing an evaluation with what you can see. That can include POCUS now right away. And it's really hard to emphasize how important this is until you're the person who's like alone in the middle of the night with someone who's really sick. And it's not like you can just go look at a computer, look at labs. Like you really need to have a system for approaching them at the bedside to make your first evaluation. So I appreciate you sharing yours with us. Auntie, what about you?
Yeah, I think there was so many great points today from Marianne and Shiv, and I think mine's just more general, right? I think Marianne mentioned this could have been a case that we definitely anchored on early on, and thinking this was, the hypotension, hypoglycemia, maybe thinking that there was infection, septic shock, but really taking a step back, involving colleagues early on, and really kind of thinking through this patient and the differential, and ultimately ended in a great outcome for her.
Awesome, Marianne. Any point you want our listeners to remember?
Oh, I think just always being humble and appreciating the complexity of the physiology and the patients that we care for, and always remembering to circle back and sort of reevaluate. And if initial impressions aren't correct, there's always time to correct. So you don't have to be right or perfect from the beginning as long as you're being flexible in your thinking.
Yeah, great point. And Shiv, we'll end it with you.
Yeah, I would say, kind of looping it back to this case, just to remember that not all lactic acidosis is from poor perfusion, and to think through type A, type B, and type D, with short gut syndrome, causes of lactic acidosis when evaluating patients.
I love it. Yeah, to have a broad differential going forward, and I'm sure all the listeners will remember that now. Well, thank you all for listening. Thanks again for being here with us, Marianne and Shiv. And we hope you all will tune in 2 weeks for our next episode. Make sure that you rate and review us and subscribe wherever you're listening. This episode was written, produced, edited by myself, Christina Montemayor. Music's original music by Eric Rogers. And we'll see you next time.